introduce my colleague with whom we'll be moderating this session, Mrs. Pédiadol and Dr. Elizabeth Bacter, who will speak to us about intubation in newborn babies. Well, good afternoon, everyone. Let's continue this wonderful day, wonderful afternoon, and I shall speak about some news concerning pain management in newborns, in neonates. As you know, that in neonatal, pain is a reality, and the latest epidemiological research shows us that, go back to this last year, that no matter what the level of development in countries is, there is a certain pain, and that it's insufficient management, and pain has immediate and long-term consequences from the physiological and neurodermatological point of view. So there are certain indications that are used for treatment of douleur. It might be associated with sedatives. So pharmacoepidemiological research in France has shown us that prescriptions of the system were taken in 30 different wards, and they looked at 65,000 newborn babies, and 45% of them received an analgesic, out of which 18% were GPA. These were orange columns, and this is 80% received at least once a year an analgesic or an anesthesia, and 60% of GPA, and 40% the rest. So, despite, of course, there are side effects, immediate side effects, and in the long run on neurodevelopment. So, it's both necessary to prevent and reduce the pain in these procedures, and at the same time develop alternative molecules to avoid side effects later. There are three points that I'd like to share with you. Firstly, it is pain that is due to laryngoscopy before having access to the UAS, and this was done by the French Society in 2023, and then a recent article of consequences on neurodevelopment in 5-year-olds following exposure to opiates with or without midazolam in the prematurely born babies, early preterm babies. So now concerning UAS, as you know that this access is done through intubation or through the installation of and it's extremely stressful and painful. It's 8 on 10 in terms of scale, and it is done, of course, it's all programmed. There's a special analgesic that's required because it reduces the pain introduced by the procedure. And the American Academy for Pediatry in 2010 made some recommendation, and that was to associate a fast-action opiate with a cure. But there's a lot of difference in practices, and there was certain things weren't updated since 2010, and between the countries and centers there's a lot of difference, and between observational units that you see over here and declarations that are made. So what you actually say is not actually what you see in practice. So in 674%, it was just a declaration that was made, and this was in intensive care units. But when you go and observe, so EpiPen 1, which was in 2005, only 56% of intubation was done with specific sedation, and 46% in EpiPen 2 in 2011. It's the same thing in the birth room. So 72% at birth said that they used a specific analgesic before intubation, and it was 5% in EpiPen 2. So you see there's a great disparity between what they say and what they do and what they feel they've really done. So we had to update all these practices, and we proposed a certain French recommendations. So the group unit, we looked at 403 publications, and we classified them according to ERC, and we made certain recommendations of good practice according to this grade, which I will speak to you about very briefly. And now, you define how powerful these recommendations are. So A is extremely high, and it's absolutely got to be done, and so on and so forth. In the scale, when there's absence of proof, we wonder if it requires expert analysis. As now, sedation before intubation, tracheal intubation. So if it's an emergency, which is not a vital emergency, if it's immediate and vital, then of course you cannot do this analgesia approach for the eye child. But otherwise it has to be a grade A+. That means it must be done. If there's no hemodynamic disorder, what is proposed, and this is grade 1, so this is propofol with atropine, but otherwise it would be synthetic morphine with curare. Next, and this is the opinion of experts. If this is not available, or if you don't wish to use it, you could use morphine plus midazolam and atropine, or ketamine and intranasal midazolam. So what you should give is provide a pure product, because it is too strong, or through intravenous systems. Now for Lisa, there'd be no curare, because this is for spontaneous ventilation with the child, and the first proposal would be to have propofol with atropine and ketamine or fentanyl. Concerning neurodevelopment consequences at the age of 5, when exposed to opiates in preterm babies, there's some data on morphine, and these are contradictory, and there are just 3 researches which have been done on the brain, developing brain. There are 2 which are French and 1 which is American, and this research is fairly old. But the ones which have a maximum number of children. So the oldest one goes back to 1997, and these were children exposed over 7 days. Now, between sedation and analgesia, there was no difference. And for those who were exposed for less than 7 days, and only 7% were actually exposed to it, to both sedation and to analgesia. In 2011, we looked at the development of 2 years old for a population which was carefully selected. It was 922 preterm babies who were intubated at age 1 and at age 24, and they were exposed. And then there were those children compared who were not exposed to opiates, and at the age of 2 there was no difference between those who were exposed to it or not. In an American research, which was more recent, 2013-16, which looked at preterm babies of under 6 weeks, 26 weeks, they looked at neurodevelopment of those who were under 2 years, both exposed to opiates and to BZD. And in this cohort, children who were not exposed and those who were exposed for less than 7 days had a comparable neurodevelopment, but those who were exposed for over 7 days very clearly showed a lack of neurodevelopment at 2 years for older children. So far, we don't have any data, and so we looked at what they became at the age of 5, and this was in EpiPhen-2, goes back to 2011. So the preterms are between 24 and 34 weeks. So we tested them in their movements, sensorial behavior, and the brain. So these children were continuously exposed to either morphine or sufentanil or fentanyl and or midazolam. When you look at the results, you've got about 3,000 children in this cohort. So you find that the most preterm babies between 24 and 27 weeks and were the ones who were most exposed. So in gray, it's non-exposed, and in light blue, it's just opium, and in blue, it's a combination of 2, and in 3, it's all 3. So amongst the preterm, where it's opium and midazolam, it's 2/3 of the children between 24 and 27 weeks who were exposed to this medication, compared to and as opposed to those who were slightly older and with a less mature brain. Now, neurodevelopment in 5 years. After adjustment, that is, when you look at one element in neurodevelopment, you have to account for everything that might have an impact on the neurodevelopment of these children. And that's where we make certain adjustments with statistical methods. And here we have two models. So in one model, you look at certain maternal factors like a mother's age at birth and socioeconomical status, a reason for premature birth, and the use of steroids. Neonatals was the second model. You had the same variables, plus we added severe comorbidities, which might be severe complications of preterm birth, retinopathy, retinocolopathy, etc. So they themselves have a negative impact on brain development. The results are as follows. So in model 2, when you adjust just the first, according to the first factor, the first reference, you find that children who were not exposed or less than 7 days, they had comparable development values for those who were exposed for more than 7 days. And this is just true for both midazolam and opiates, not just for opiate alone or for midazolam. It's just a midazolam. We didn't have enough cases. So for midazolam, there are more severe and moderate disorders. And this is associated with a total score, IQ score. But when you look at all these and severe comorbidities, you have all these side effects or all these disorders. So it's at 137 and the right one is 0.37. So it's not very far from 1. So that's not very far from normal activity. So that means that if you're exposed for more than 7 days to these drugs can be negative for neurodevelopment. So those who were, but these are data that go back to 1997 and 211, but the more recent results are roughly the same, with a greater exhibition for the preterm babies. There's a lot of variability. Under 7 days, it's almost like being not exposed, but if it's over 7 days, it does have adverse effects, particularly if you combine midazolam and opiates, and this has an impact on IQ in general. And we also looked at the gender. Boys are more vulnerable, and this affects them at all ages of birth. So it affects neurodevelopment, both moderate, severe and light, but the role of comorbidities is extremely important, leading to severity of these cases. So now, of course, you must keep sedating children, but you must be careful concerning for how long, especially if there are severe associated comorbidities, and therefore it's extremely important to about the kind of molecule you're using and the dose that's being used. And it would be useful to think about the use of alternatives like dextromethorphan, which could be an alternative to the normal sedatives and analgesics. So what exactly is it? It is an alpha receptor agonist, and it has effects which are both anxiolytic and of sedation, and it stimulates the natural pathways of sleep and maintains spontaneous ventilation and of the UAS. It has an analgesic effect. It is a neuroprotector, but it also has these impacts on the receptors, and which could lead to vasoconstriction and bradycardia. It could also have a plasmatic peak, which you get at 1 hour, and it has a half-life of half an hour.
So it's not a new molecule. It's something that's been used with adults for several years, and so it reduces the duration of ventilation. It is increased bradycardia, but it has no impact on mortality. For children that are under 1 month, it reduces the consumption of opiates as well as the usual drugs used for resuscitation. It can have a hemodynamic changes, which means that you need to limit the doses or fascicular filling, and sometimes the discontinuation of treatment. Newborns, there are no random control tests today, but use is on the rise. And in this American study, we can see that there were almost 400,000 cases of prescriptions. In 2010, it was used in 0.003% of cases versus 0.185% of cases in 2021, with a slight reduction of the use of opiates or opioids. A recent study out of 6 studies listed 250 patients and showed that it's effective when it comes to sedation and analgesia. There's a less use of adjuvant sedatives and analgesics. There is a reduction in extubation time and the duration of mechanical ventilation time and reduction in KTC time. But a very recent Cochrane showed that we really very heavily need to do quality randomized testing in order to validate the use of this molecule in neonatology. So what is the outlook? There are 6 random control tests underway internationally, and we're going to be kicking off with 2 PHRCs soon. There's one that will be called DEXPRE that will be comparing DEX to MDZ, and there's one called Divigno that will be comparing Dextio with a placebo. And for very premature infants before 32 weeks. And what's important is that there'll be a neurological follow-up in these 2 studies at the age of 2 years and 6 years. And just one last piece of news. This wasn't planned, but I saw this. I added this when I saw the news. There was validation for the Evandel scale in the maternity wards, and this paper was accepted on Friday in pediatric and neonatal pain. So for all of those who work in this field, you will be able to use the scale. It's now been accepted by the scientific community. And so in conclusion, pain management is essential. You need to implement and monitor best practices. And relative to the recommendations made by the French Society of Neonatality, we've just done the Supremio Neo study to see what the follow-up is of these best practices. There's possible neurotoxicity when opiates are used, and especially if they're associated with benzodiazepines. And the development of new compounds is thus necessary, and with a long-term follow-up, which is indispensable. We also have to encourage the use of non-pharmacological means. So all that's used, sweet solutions, dummies, pacifiers, there are many possibilities. Care has to be individualized, family-centered, and always encourage the presence of parents. And in neonatology, research continues, and so watch the space for next year. And so, hi, I'd just like to take advantage to thank the committee for having invited us here. And today I'm here to represent childcare nurses. And I've understood that I also have to enter the club where everything is traced and tracked in writing. I represent what we refer to as holistic care. And the survey for I'm really happy with the quality of the exchanges, and all the presentations have shown how specific taking care of children is. And it's my pleasure to be able to present Corinne Guiton. Today we're speaking about innovative practices, and when it comes to sickle cell disease and why it hurts so much. So thank you very much. Thank you to the organizers. And when it comes to sickle cell disease, it's still a complicated matter, and that's not a very new piece of news. But we're hoping that there'll be more hope on the horizon soon. So I have no conflict of interest that might influence my presentation. And so I'd like to start by presenting a couple of figures just to set the scene for you. There are 500,000 births every year. In 2017, here you have the number of births. I got to admit, I can't see very well anymore, so kind of betraying my age. So thank you for confirming that nobody can see anything, so it's not just me, says our speaker. And so there's sub-Saharan Africa that's been highly impacted with Nigeria and the Democratic Republic of Congo that have a high level of incidences, as well as in India. But it's something that we find throughout the world, and that's why we think that there's 7 million people that live with sickle cell disease, and the WHO predict there'll be 14 million people suffering from this by 2050. So it's a global issue. When we look at the figures in France, in terms of detection at birth, in 2011 and 2022, we've doubled the number of births that we've had in France. And so it really is a general health issue. And so very quickly, it's a qualitative anomaly with the blood where the red blood cells are replaced by S blood cells, and you can see this in the photo. And so it's a deformation, and it rigidifies the red blood cell, so it loses its flexibility. It's an autosomic recessive disease. And most of the patients that suffer from this have are SS. There are several different types of syndrome, but it's the SS category that are the biggest group. It's in terms of its manifestations, it's chronic hemolysis. It's fragile and it leads to anemia very quickly. There are vaso-occlusive crisis. It gives rise to significant infection, especially at the pediatric age. And it's a disease that affects several organs. And it's very hard for those who suffer with sickle cell disease to age very well because it affects many things in their bodies. And so for a vaso-occlusive crisis, even though most of the Serie O, it's one of the main reasons for consultation and hospitalization. We said that it's really before the age of 6 months because we're supposed to be protected, but there's no trigger factors as far as we know, as cold or infections or dehydration. And when the young teens are doing Ramadan at the moment, and so a lot of them coming into the ER and also there's exam stress. But in general, we say that an attack or a crisis will last 1 to 7 days, and it can go anything from a couple of hours to several weeks. And for reasons that we don't understand, it gives rise to pain and a lot of bone pain. And so that's quite the mystery. But like I said, many of the organs can be affected, the bottom of the back and the sacrum or the lower limbs. And when we do a biological test, we can see that it's a little bit like a civil war. There's a specific inflammatory syndrome, and which is the result of stress on several of the tissues. But we all agree to say that these are one of the diseases that gives rise and creates a lot of pain for the patients. So which patients are affected? These are the figures that come from the French social security system, and these are the figures from 2011 to 2016. We looked at the number of hospital admissions because of vascular-occlusive crisis. So there's group 1, not ill very often and in hospital often. And so it's the young adult population that have the biggest number of crises, and again, not easy to handle. And alongside the attacks or the crises, we have some graphs that represent this, and there are 4 phases. There's the prodromal phase, where they start feeling some of the effects. Then there's the initial phase where it becomes painful very quickly on a level superior to 8, and that lasts for a few days. There's the established phase, and then there's the resolving phase. And the dotted line is what we call the basal level. You can see that the platelets go up, but when the patient is suffering from a severe crisis, and this is one of the difficulties that we face with our ER staff and the hospital staff, they know about this. It's when we talk about severe attacks, we know that it's going to become complicated with the HCPs in the ER and in hospital. We know that. And initially we thought it was quite simple. We had a red blood cell and it was deformed because of the hemoglobin S. that had been deoxygenated. It had, which as a result modified the red blood cell, and when it became deformed, then it would block microcirculation, and it leaves rise to ischemia and tissue suffering, and so the consequences are quite clear. But now we know that the red blood cell doesn't act on its own. It's just the head of an association or combination of things, and there's several, because in addition to a sick red cell, it's very excited. It takes on board with it the mastocytes, platelets, and all of this alters the blood rheology, the blood flow, and gives rise to vascular obstructions, and so the whole system is under stress with inflammatory cytokines and a deficit relative to NO. So the vessel retracts. It's like having a two-way highway. It becomes, there's only one lane, and so that makes things very difficult to get around. And all these substances that are released by the platelets, the white blood cells, the red blood cells, sometimes we need perfusion, and once the blockage has gone away, there's still remaining excess, nociception, which becomes recurrent, and inflammation. And these are very algogenic substances that put a lot of stress on the nerve receptors, and so it has a neuropathic effect with peripheral hyperalgesia. And I'm going very quickly, says the speaker. I only have 15 minutes, so I have to do this very quickly. Anybody has a problem, see with the organizers. He is indeed going very quickly. So in summary, if your red blood cell is affected by all the phenomenon with inflammation and stress, and it activates many things in the body, and it all gets worse, and then you have a type of vicious cycle. So it's like pulling on a plastic, and after a point in time, the elastic will break, and then all the thresholds will fail, and all the effects become amplified. And that probably explains why the three types of pain that are described. You've got acute pain, and with patients in hospital, there's acute pain, which becomes a chronic pain, and then there's also acute peaks in a context of chronic pain. And so not only do we need to take action on the disease itself with the medication required, but it's also important to look at the psychological and emotional fallout caused by the amplification of the effect, and which becomes even worse when there is sickle cell disease involved. So for chronic pain, we have a scale that we use, and I would say that we don't use it enough in our practice, and it's been validated for sickle cell disease. It's called PPST, and the physical measurements in terms of the expression of pain in practice, saw, as well as psychosocial features, and we measure the impact of the pain or of the disease and the effect that it has on the daily reality of the patient. It's very difficult for me to do exercise. I'm always worried about having pain, and when they answer yes to the questions, they get a point, and that gives rise to a score. So you can see that there's a total score out of 9, because there are 9 different elements that are. And so from 0 to 2, it means that there's a low risk of developing a chronic disease, but as of 3, things start getting more complicated, and anything above 3, it means that you've got a risk of suffering from chronic pain, and probably you need a special treatment regimen. And when you look at the figures amongst the adults, it tends to go up with age, and we saw this with teens and young adults. And we know that 50% of our patients are going to suffer from chronic pain, and 30% of adults are sore 90 days out of 100. And I think as pediatricians, conditions, it's worth estimating and taking into account how these patients will age and the effect it will have on them thereafter. And this diagram is a summary of everything we've seen. There's the biological dimension with the physiopathology of the disease, as well as the psychological and emotional aspect that needs to be taken care of, as well as the social impact. Sickle cell disease, there's a complicated social context. There's a certain degree of precarity, and this has an impact on the expression of the disease, and all these aspects have to be dealt with if we really want to provide effective care to the patients. And so having a better understanding of this physiopathology will help us to provide better care to our patients. And what we have here are the different players. You've got the mastocytes, the red blood cells, the white blood cells, they're all there. All the usual suspects, the blood flow, the vessels, and you can see that we have various adhesions, and then there's the release of several substances, which will then will excite the peripheral nerve and the marrow and go right through to the brain. So in every stage of the development of this disease, we're going to have to come up with a type of therapy or a treatment or a practice to attenuate the pain and maybe restore the various circuits for treating the disease. In blue is what we've done with man. In the other color is what we did on the mice. And in green, we've conducted trials on both. And so there was and we used arginine to improve the vasodilation of the vessels. And we've also tried to take action onto sickle cell, on the sickle cells themselves, trying to prevent the deformation. And the mastocyte also releases many substances. And the psychosocial dimension is also important, making use of hypnosis and virtual reality that can all help with the pain, use of cannabis. And so there are many opportunities that are possible. So now we have a plan. And the first plan that we have is we've got to try and prevent the first attack from ever happening, and try and prevent its recurrence, and so that by pulling on the elastic, it doesn't break. And so I've been told my time is up, so I need to go very quickly. And so there's hydroxyurea, and there are marrow grafts. And when you put a graft on a little one, it goes well, but with teens, it becomes more complicated, and the pain lasts. We are able to cure them of the disease, but the pain lasts. And unfortunately, in France, we have some drugs that we have. But despite that, it arrived in France and 18 months later we had to withdraw them from the market. So for the time being, the only solution we have is hydroxyurea. And so we said, okay, you give a good dose of hydroxyurea to everybody as of 9 months in order to avoid any complications. And so when the attacks happen anyway, we have solutions for that with the list of drugs available. There's ketamine we spoke about, gabapentin. This is something that's very interesting. It's an interesting option, even though we could do better, I think. And just a couple of words about arginine. It's it's an acid aminate. It's easy. And it's been effective in random controls in Africa versus a placebo group. And they've also
So now, of course, there are the pharmacological interventions also, which would prove exactly what you've said. There's also yoga, if you do it. I don't know. I saw a dog work, and it worked on a dog, so well, perhaps it will. 30 minutes of yoga and you feel much better. You can also talk about TENS, and what's really amusing is curcumin. It works in mice, but what about human beings? I don't know. There's a team also who tried to use it all, a multidisciplinary approach on 116 children, so they did everything. And they identified 5 different working thinking on ways of working. Firstly, of course, it was reception of the child at emergencies. That's just a coincidence. I don't really believe in it. And then a better reception at hospital, and what happened at home, what happened from the pharmacological point of view, and also psychological resources. They did plenty. There were personalized protocol. Everything was done, and it works. In 5 years, there were 61% who were hospitalized for fewer days per month. But of course, it requires a multidisciplinary team, but you can do it. And thank you very much for your attention.
Vous ne l'avez pas vu, mais les globules rouges étaient en tenue sportive parce que l'activité physique
You
adaptée
didn't see because my red blood, my RBCs were also in their running gear, you see. As you can see, I was in running gear, and so there you go. That's what got me going.
Nous allons recevoir l'association Sparadra,
The
Juliette
Sparadra
Roussel.
Association,
Un
Juliette
grand merci
Roussel, and thanks very much
pour l'association Sparadra qui, pour ma
for
part,
Sparadra
m'a
Association,
accompagnée,
who
tout le
were
long de
with
ma
me
pratique
right through my
professionnelle, notamment à
professional
l'hôpital,
practice,
avec
and particularly in hospital, particularly with all these posters, which was so useful. Thank you.
Ouais. Je transmettrai à l'équipe parce que moi,
I'll share that with the team because I've only been recently with Sparadra, but I'll share your message with the team. So good evening, everyone. And today I'm going to share one novelty from Sparadra. As a team, we didn't know which one to choose because there's plenty of good news, and we decided on the latest, which is a new poster we've got on burn care. So in this poster, we inform children, parents, and to help professionals who help them. The aim behind it all, as with several tools that Sparadra uses, is to prepare children better for the care that will be administered and to have a better pain management for them. So these 2 points, which are at the very heart of everything that Sparadra does. I confirm that we can't see anything. I'm also quite old. So this poster, just like, or this brochure, just like all documents for children, has 2 parts to it. In the first part, it's just for children, and in the second part, that's meant for parents. So why do we have something on burn care? Because children with moderate burns are most likely to go to the emergency section and then come home. And treatment with changes in dressings will take place over a short period of, let's say, 1 or 2 weeks. However, certain things will have to be set up at different levels, as you'll see in this poster, which I'll be sharing with you. And besides, most often the dressings take place at home, and often it's by a private nurse, and sometimes it's done in a day hospital also. Since there's several dressings, it's a good idea that the first dressing is well done and the following one as well. And since things have to be done, it's important to have full cooperation from the parents. And like all documents made by Sparadra, it is written in a very simple language for children. I can assure you, one would think it's simple, but it's really not that simple. How to express it all in simple language, and of course it's with all those famous illustrations with our very experienced graphists, so that children, graphic artists, so that children understand. As I said, and I'm repeating, it's meant for children, parents, and HPC. It was made thanks to expert working group representing several establishments, and so it was a very multidisciplinary group. And like all the documents, we also have revisers who revise the document with the help of professionals, parents, children, and also other associations. Now, here it is. This is the single document. It starts off by giving a definition of ideas that you will find right through, for instance, what's a skin, burn, and healing. Then you've got 3 little vignettes which will introduce the pain management, the care management. Firstly, that there'll be dressings, and then there'll be systems for fighting pain, plus a monitoring of the child's general state of health. On the second page, these are answers for questions that are often asked, frequently asked questions. How long is it going to last? How long will you change? How often will you change my dressings? And who's going to do it and where? Once you've dealt with these questions, the next step is a description in detail and in the different steps how the dressing is changed. This description, depending on the protocol, is illustrated accordingly. Either it's with flamazine or with ergotul. After this explanation, then you look at all the right practices when it comes to pain management through medical means and also non-medical means that you've been listening to all day long. For instance, the presence of parents, and we also mention wetting or humidifying the dressing before removing it, plus the use of hypnoanalgesia or distraction. And for children who will be getting their changes done in hospital, there's also perhaps the use of Meopa. Then there are 3 pages of recommendations and advice. On the first page, it's concerning what should be done on a daily basis during the healing period, particularly cleaning up and toilet of the child, the way the child should be dressed, any itching that's linked to healing and scarring, and pain. On the second page, you look at the means that are available to improve and accelerate the healing. In other words, that you have a high-protein diet, and in the importance of drinking a lot of liquids, of taking rest. So that's you answer the question, do I go to school or not? And also the care that the child must take of his own dressing, and make sure that it's really on the wound. On the very last page, which is for children, this is advice for helping the healing concern and all the information that's required. It's both children and parents. When they come to the emergency, they ask, what will happen after? What will my skin be like? So it's to talk about what the scar will look like after. Plus, all that has to be done over the weeks that come, or perhaps the whole year. We talk about ideal protection, ideal use of sunscreen. As I said in my introductory note, this paragraph information sheet has also some paragraphs dedicated to parents. Now, it's a way for parents to say the right things or find the right words to children. And once there's been some consultation, you also find that there's a lot of loss of language, of what was said during the medical consultation. So this is a written account of what one should know. They talk also about the psychological fallout, because parents might feel guilty, and then there'd be some information concerning the skin structure on burns and the different degrees of burns. It's not necessarily related to the intensity of pain, and all that a parent can do to help this healing process faster, and all that should be implemented in terms of food and drink, etc. The last part of this sheet is a little checklist of all the signs that you must keep in mind, just in case any of them reappear, that it's time to go back to hospital. Plus, here in this little box that you have, you can put in your contact now? How do we get this? How do we get this super
D'abord, je tiens à dire
information
que
sheet?
vous êtes toutes et tous les meilleurs ambassadeurs et
Now, I would
ambassadrices
say
des
that you're the
outils de
best
Sparadrap
ambassadors
auprès des
of
parents.
Sparadrap
On n'a
tools
pas la
for
possibilité de
parents.
faire une communication à la télé avec des super
We
pubs et
can't
des
really
4x3 dans le
communicate with
métro.
wondrul
Donc en fait, c'est vous,
ads
c'est vous, nos
on
ambassadeurs
TV
et
or in
ambassadrices.
metro stations.
Donc ce
So
que
we
vous
leave
pouvez
it to
dire
you.
en
It's
fait,
really word of
nos fiches, elles
mouth.
sont toutes accessibles sur
Oh,
notre site
and
internet.
all these
Donc,
items are
les
available
parents
on the
peuvent y accéder.
internet,
Alors, elles sont
and
pas
you can
imprimables, elles sont
easily see them.
feuilletables.
You can't really
Vous avez la
download them, but you
possibilité
can
d'imprimer sur notre site en
consult them.
revanche un
And
poster
on our
avec un
site, you
QR
can
code qui
actually look
permettra aux
at this
parents
poster.
d'accéder
You can
directement
flash the QR code,
à la
and so that
fiche.
gives you
Et
access,
bien
direct
évidemment,
access.
elles sont aussi, elles peuvent être commandées sur notre
You
site
can of
internet.
course order them
Je vais prendre ma casquette
on
de
internet.
directrice
So here,
d'association,
as the director of
dont
this
la situation
association,
financière n'est pas toujours très facile.
and I must say that our financial
C'est
stability is
important
not
pour
all that
Sparadrap pour
great.
qu'on puisse continuer à faire des fiches,
Please do
imprimer des
make your
fiches, à les
donations so
mettre
that
à
we can
jour,
keep printing
d'avoir
them and
aussi des
updating
commandes
them
de
and
nos
receive
supports
orders
sous format papier.
for
Et
what
puis
we
c'est vrai que le
provide
papier, quand on est
in
petit, c'est pas mal
physical
aussi.
format. And it's also true that
Cette
when you're
fiche, c'est la
small, you like to
27e.
have a paper.
Donc, il
This
y en
is
a
the
plein de
27th
petits
of its kind. There's several
Donc
others too
n'hésitez
that
pas à
we
aller les
had.
regarder parce
So
que
go
là,
and check
au
them out
stand,
if
on
you
voyait,
want
ah oui, je
to,
connaissais
because
là, mais je
on
connaissais pas
the
celle-là, mais c'est super bien.
at
Il y a
the
des
stall
vraies
outside,
ressources
we
à
found a
creuser.
lot of you saying that, oh, I know
Donc,
this one,
on
oh, I
compte
didn't
sur
know
vous
this
pour les
one. So
faire
it's worth
connaître.
just
Je
going
vais
through
faire
them.
un appel.
And I'm
En
making an appeal.
2025, on va faire
In
on est en train de commencer une fiche
2025,
sur
we are
l'ostéosynthèse chez
starting
l'enfant.
something on
Si parmi vous,
osteosynthesis in children.
l'ostéosynthèse n'a pas de
Now,
secret,
if osteosynthesis
de
is no secret for you, then we
Vraiment.
need you. We really need your
venez
help.
partager votre savoir
Come
et
and
votre
share your
expérience.
knowledge and
Je suis
know-how
là,
with us.
donc venez me
I'm
voir.
right here, so
Sinon,
come and see
contactez
me
Sparadrap.
or
C'est pas
get
très
in
loin,
touch with
c'est une à deux
Sparadrap.
réunions en visio, quelques échanges par mail, vous inquiétez pas, ça
It
va pas
won't
vous
take very long. It's just one or two
Et
video
comme Sparadrap, c'est plein
conferences,
de
and it's just
ressources,
once or twice
vous
a year.
avez des formations.
Besides, you have several other resources. So we've got these
catalogues.
catalogs. I didn't have time to talk to you
Et
about
vous avez
these.
le catalogue avec tous les outils
You've
qui
got
vous
the
permettent de
catalogue with
savoir
all the tools that
ce
enable
qui
you
peut
to
vous
find
être
out
utile
all
dans
you
votre
wish
pratique
to and all that might be
professionnelle
useful
pour
for you
accompagner au
in
mieux
your
les
daily
enfants et leurs
practices to
parents.
help children and parents.
Merci.
Thank you so much. Thank you so much, Juliet.
Bonjour à tous et à toutes.
Hello, good evening,
Déjà,
everyone.
merci à
And
Pédiadol
thanks
de
ever
nous
so
avoir
much.
invités
Thank you,
aujourd'hui
Pédiadol,
pour
for
parler
inviting
ici.
us to come and speak to you
Anne-Laure et
over
moi,
here.
nous sommes ravis de pouvoir
Laura
vous
and I are
présenter notre
delighted to
escape game qui a
share
été
our
réalisé
escape
dans
game
notre
with
service
you,
de
and we
réanimation
made it
pédiatrique
in
à Lyon
our
par le
resuscitation
groupe douleur.
ward
Nous
in
sommes
Lyon, and this
les
was made by the
représentantes ici, et
pain
on a une
unit.
aussi
We
de nos
represent
collègues
them,
qui est ici pour nous aider.
and we also have some of our colleagues who are present
Ce
over here.
groupe douleur, il a pris
So
forme,
our
repris
pain
forme parce qu'il
unit
existait déjà,
was
mais on
brought
l'a
back to
refait
life. It
naître
existed,
fin
but we gave it more
2023.
life end of
Il
2023.
est composé
It
de
is
plusieurs
made up
infirmières
of
auxiliaires de
several
puériculture
nurses
avec un
and
médecin référent.
assistant
Et c'est suite à un
nursery
gros
nurses.
turnover au niveau des
And because there was
paramédicaux
such a
qu'on
lot
s'est
of
dit qu'il était
turnover in
important de
this field, we
sensibiliser
felt it
l'équipe
was important to
sur
make the
l'ensemble
team
des moyens
aware of all
médicamenteux et non médicamenteux qui
medical
étaient
and
présents dans notre
non-medical
service par le biais de
resources that
différents
were
supports.
present in our
Escape game.
department,
Mais également de faire des
including
rappels et de
escape
valoriser
games,
les
and also
connaissances des
to
plus anciens
remind,
professionnels déjà en poste au sein du service.
to renew and
Du coup, on a
upskill
réfléchi et encore
our
réfléchi.
practitioners.
Et
So we
on s'est
thought
dit
very
qu'il
hard, and we
fallait
kept
créer des
thinking very
ateliers
hard, and we
axés sur
felt
la
that we
prise en
should
charge de la
have
douleur, avec des
workshops
objectifs
concerning pain
particuliers. Donc déjà,
management
c'était
with
de
very
mobiliser,
specific
de remobiliser pour certains,
goals. And so
déjà,
the
qu'est-ce
idea
que
was to
c'était la
mobilize
prise en
and
charge de la
remobilize
douleur,
people. Now, what exactly is pain
permettre à tous
management?
les professionnels
So
du
that means you
service,
enable
déjà,
all
de
people
s'approprier le matériel qui était
in the
disponible,
unit
de
to use all the material that's available and to think about the kind of methods, both medical and non-medical, that could be used, and also to use them in their daily practice. That it become a reflex in long-term prevention for pain assessment and pain treatment. So we set up these workshops for the entire team. These were medical and paramedical. And it was just voluntary. They came in and they subscribed to the days that we had set up, the dates that we had, plus there was, of course, the daily work that they were doing. All time spent of it was part of their working life, also working hours. We also provided a lot of information and a lot of awareness. We had several workshops. There was the magic massage. We had two colleagues who belonged to the group and who were trained by the foundation whom you met at the foundation. That was Roche Posay. There was also a relational simulation. and Solon introduced you to hypnomassage. She helped us also to do this, to create this whole game. And then finally there was that e-escape mailing, and that's what we made. It's originally ours, and that's what we'll speak to you about. So imagine a world where learning becomes a very, very important game. An e-escape pain game is mixed up with the more serious pediatric resuscitation, and there's much exciting about this adventure. So our aim is to transform this learning process into something that's interactive and that you won't forget. And through it, the different participants learn new skills and are completely immersed in a very exciting scenario, which is fun. It also favors a greater communication, cooperation, and teamwork. It brings everyone together. So what is an escape game already? I think you all know roughly what it is. So it's riddles, and it's very immersive, and the players have to solve a number of puzzles in order to complete their mission. So we used a clinical case, and that was the leitmotif of the entire game. The idea was to be as realistic as possible so that participants identify with the situation really well. So what we used, the context was back from the operating theatre after peritonitis. So there's a child suffering from pain and who requires very special management of his pain. And we also used, we thought we should use entertaining tools and very attractive ones. So we used riddles and clues. You can see them over here. There were memories. There were certain codes also that we used. There were audios, there were little audios, what should be said and what shouldn't be said, what would you choose between the two. Also, realism. So we created avatars of each members of the group, the pain unit. That's me, by the way, that's me. And we also had photos of our ward, so that it appeared to be more realistic. The fourth one was, of course, bundling it all up together. That was not so easy. But we have an excellent colleague, a nerd, who uses a software. And thank you, Martin, for that. So he put it all together. It's a 45-minute game. So ideally, you should play with a pair. So a nurse and an auxiliary. So all you need is an internet connection and your computer, and the deed is done. So we have 3 different missions in this escape game. In the first one, it's about observing, reassuring, and talking. In this first part, you receive the child and family in your unit. So here we have 2 different approaches. You've got audios that professionals should listen to and decide which one is more suitable to receive this child and his family. And then we were trying to be more reassuring, so things which are very simple and that need to be thought about. So you give a cuddly toy to that little girl, turn on her night light, her television, and you can't see it, but you'll see she's got something else as well too. We use this screen up there, and that's for children. You jot down various things on it, a pain scale, etc., age, name. So it's like a checklist to find out what the child's pain is about. It was a bit of a nuisance because you couldn't see what the issue was. Now, this was all about a stomach pain. The child complains about a pain in her tummy, and you had to define this pain. And how do you describe it? So there were different scales, different pain scales, and and to see which was the best scale. So these mem cells were not blocking you even if they were wrong. And if you can't find your answers after 45 minutes, that's all right. You can still quit the game. Then we talked about analgesics which are available in our unit. So there's a table here with all the analgesics classified according to the stage at which they should be administered. Some actually were quite surprised by it, but so it's a good way of reminding you of the family and explaining when what should be used, because this is for specific pain, what should be used, and what can be required of the doctor. So when are we going to use this analgesic? Where will we find it in our pain unit? And for this particular patient, should we go through IV or should we try an oral method? And why this choice and not something else? Plus, there was a reassessment of pain because analgesics have to be administered, but then you check the results, as you heard this morning. That was very highlighted. Plus, of course, there was level 3 analgesic specificities like traceability and so on. The last mission was about non-medical means. So here we had 2 multiple choice questions concerning these means that are available in the unit. So there was hypoanalgesia. Once again, 2 different audios with the same scenario, but there's different language that's used, and our mission finder was supposed to see which one was the most appropriate.
At the end of each of the missions, there's a summary, and recognizing that the mission had been validated, and also with a list of everything that they encountered during the course of the mission that's just been completed. And so after each of these workshops, we handed out questionnaires to see what they thought about the training course and if they were happy. So this was for the feedback. And the outcome was that they were satisfied with the quality of the training that had been provided. They enjoyed the fun aspect as well as working on the basis of clues which helped them to move forward in the game, as well as the way they managed pain. They claimed to have changed their practices because we had reactivated basic notions and certain reflexes which they had forgotten or which they had lost along the way. And so what we saw is that once the training had been concluded, the practice had been improved in the ward. People were more attentive, and they used non-drug as well as drug-based solutions better, the Miopa, EMLA patches and things like that. And because we don't like to get bored, we said that we would continue on the journey. And so we're still thinking in terms of another vocational training modules. So we're developing a training course on hypnoanalgesia. That's a big demand coming out of the team. And so we're looking at simulations, and we're busy creating a Trivial Pursuit type of game. So if you come and if you want to invite us back next year, maybe we'll have new things to present. And because it doesn't end there, it's now your turn. So we ask that you pull out your phones. I'm not quite sure if we have time. Well, you can still scan the code, and you can test it on your own end when you want to. So thank you very much. Well, when it comes to prevention, we speak a lot about care and treatment. And what about the preventive dimension? And in terms of the way we support and accompany parents, and I'm thinking in terms of sickle cell disease, what are the measures that have been taken? And parents have an important role to play when it comes to supporting a child that has sickle cell disease. They have to drink a lot. They have to hydrate, cover up in order to try and prevent the attacks from happening. And the parents have a role to play in that. So we have to teach them to manage all of this, as well as handle pain relief at home. Giving 1 or 2 tablets or a third tablet, it can be difficult. And unfortunately, sometimes we have patients that have families who don't know how to read French. So a suggestion for Sparadrap, could we have some of the information available in other languages so that people who don't read French can have access to your information sheets? Because that would be very interesting in order to accompany them. And so we have some video animations available. We've got 12 of our modules or our information sheets that are available in video animations. And there's lots of appointments, and it means that they land up missing school. And when they're missing school, it means that they're not doing well. And it can have quite a major impact, and sometimes the support and accompaniment that's required can be underestimated or undermined. Well, when it comes to TENS and sickle cell disease, do you have any experiences that you can share with us? In our department, we don't use TENS, but there are some colleagues that have spoken about the experience. It would appear to be something that works, and we probably have to conduct an assessment and carry out a trial, but it is something that theoretically works. And it's happened that we've used it twice for teens with chronic pain, and 2 of them accepted, and the third one didn't like the feeling and the sensation of the TENS. But I think it's an additional tool that we could use more often, and maybe it's not a go-to, maybe we don't think about it often enough. And for Daniel Anka. And this morning I gave a presentation on the study that was conducted that showed that children with sickle cell disease exposed to MIOPA but the data that I presented dates back to 4 or 5 years ago, though. And so now time has gone by, and with the explosion of recreational usage, has that changed anything in terms of the use of MIOPA? Well, the patients in our cohort, we haven't had any parents or children who have used this recreational activity. We haven't seen that. MIOPA can be complicated because our colleagues don't use it at all. And that is really one major way of being able to take care of these patients in the ER. And our adult colleagues, they say that they're very afraid that there will be abusive consumption with some very severe complications. And so we don't have MIOPA. There isn't any MIOPA. And I don't know if it reassures the patients, but it does reassure the doctors for whatever reason. And we haven't noticed any misuse of this treatment. What we have seen misuse of is codeine, which gives rise to significant sleep problems. But this is something we need to try and identify. But sometimes when the teens say, are you sore? And they'll say no. And then we have to wonder what type of analgesics did you take and ask ourselves why. So thank you very much. And we're really happy, Elizabeth, to hear that studies on the use of analgesic during the neonatal period is continuing. With introduction of the use of Dextor. And so it was very pleasant to hear all these conclusions. I'm now going to hand over to my colleague and give her the pleasure to conclude on the escape games. Well, the importance of training and accompanying and supporting professionals is very important, and I hope it will extend to other departments too. And that your hospital will become a reference when it comes to training and development. So we eagerly await the next game that you will be releasing. Elizabeth, I have a question for you. So thank you very much for having spoke to us about neonates and newborns. And you said that with the recommendations and the grade scale, you land on propofol. But propofol has to be administered by anesthetists. Well, that's where the difficulty lies. In the literature, they spoke about propofol And for the Americans, it's a combination of rapid opiates and curare. And we don't have that culture because cura and fast-acting opioids has to be done in the operating theatre. And when we undergo our training, we trained to use propofol, but it really depends on the team. We are not anesthetists. And that's why cura with fast-acting opiates hasn't really taken in neonatology, but ketamine is... we don't actually have anything. So it's either nothing or it's morphine, and morphine doesn't work, or it is midazolam, which has contraindications. But you need to know how to use them and prescribe them, and you need to keep an eye on the hemodynamics and to monitor them. And so that's why monitoring is mandatory whenever you inject any anesthetic product. And so we are pediatricians and not anesthetists, but it's that or nothing at all. But as an anesthetist, I can tell you that for a very long time, propofol was used for all resuscitation departments for adults and children. But the use of curare, we don't use that at all. With propofol gives us an opening to intubate under good conditions. And that's the difficulty when you read the literature. We analyze that which has been published. And so there were a lot of criticisms that say propofol isn't an analgesic, but it's a powerful sedative. And in order to do cesarean, they use propofol, open up the stomach, and then they pull out the baby and put a strong analgesic. And a lot of people said, but ketamine, you need an expert opinion. And we analyzed literature, and there are no randomized control tests before a laryngoscopy. And so for people who use ketamine, we said, well, conduct a study and please publish it, because this is the limits of the recommendations, is that we work on the basis of publications. And the message is that you need to do a pseudo analgesia before you do a laryngoscopy, which is not urgent, and disseminate this but as a best practice. Pass the message on to the physicians who aren't necessarily in the know about everything, and then you need to put it into practice. This is what we did after the study 1 year after. So 50%, there's only been 50% people who have actually followed the recommendations, which is really a good level. And it's 90% of non-urgent intubations are carried out with a specific pseudo-analgesic. And we probably have a recruitment bias, though, because it's the centers that have accepted to participate in this exercise that have protocols in place. So we have to review the situation in the next 3 to 5 years to see how widespread the practice has become. So it's a Franco-Belgian study, which means we have an eye as well on what's happening in Belgium. So thank you very much. Well, thank you very much. And this brings us to the conclusion of today's event. We were really spoiled. Every year we think to ourselves, well, this has been a really good vintage. And we have as a good vintage next year. There was some really amazing collaboration within each of the teams, and the programs all followed on one from the other as if the people had spoken to each other before they even got here today. And in certain groups, we spoke about the power of creativity, and I thought that this day was a really good example of that and was very motivating. So thanks to all of you who attended, all who participated, all who gave presentations. And if you could go back to your seats, because we're going to play another game, and this is where we're going to be handing out the prizes. Unfortunately, for those listening into the translation, we are not going to win on speed. Pseudo-analgesia.
Ça y est, tata.
So the winners are...
Alors, les gagnants sont invités à venir nous
And
rejoindre.
so
Ils auront des
can the
cadeaux.
winners come up onto the stage and accept their prizes, collect their prizes?
Donc, Drépanantes.
And so there's Trepanantes, Charlotte, Toto.
Toto.
Who's Toto? So
Il en manque 15. Vous avez gagné.
there are 15 prize winners. It would seem that we are missing some people.
Content.
We're happy to see Clotilde in the mix.
Vous n'aviez pas confiance sur le fait de gagner. Bon, bravo encore, bravo aux gagnants. Merci.
Well done. Welcome to all the prize winners. Once again, thank you to all of those who listened in and attended. We're not finished, though. We still have tomorrow. And once again, there'll be 20 or so different workshops on offer. We just have a couple of open spots still, if anybody would like to sign up. I think there's still space for you, even though we're almost full. And for those of you who will not be with us tomorrow, we will see you during the plenary session next year in March. Once again, thanks to one and all.